Perfect. Welcome everyone to today's the start of our quality infrastructure series. I am excited to have everyone here. My name is Jennifer Wagner. I am the Director of Rural Health Initiatives at Convergence Health. And just a quick shout out to my Montana friends. I came to Convergence from the Montana Hospital Association and their Flex and H Quick program. So it's really nice to see familiar names in the chat box. So we're going to go ahead and get started. I'm really excited to offer this series for you all and kind of give some context and open an opportunity to talk about what this quality infrastructure is. So the quality inventory, or I'm sorry, I'm going to start with kind of a background on the Flex program, because that's where it all came from. The Flex program is a federally funded cooperative agreement that's led by HRSA and the Federal Office of Rural Health Policy. It was started way back in 1997 with the designation of the critical access hospital model, with the goal to strengthen financial stability of rural hospitals and ensure access to healthcare communities. The really amazing thing is through the years, the funding for this has been renewed and it's been adopted and it's been evolved to meet the current needs of rural hospitals. So currently there are 45 state flex programs, and each state has a unique work plan that supports rural healthcare quality. Measured by the MBQIP program or Medicare Beneficiary Quality Improvement Project. The state flex programs work on financial and operational improvement, population health, and emergency services. If you would like more information or you're not familiar with your flex program in your state, please, there's a link here and I'll also share it in follow-up materials where you can learn more and see who to reach out to be involved. So in March of last year, national partners for the Flex program convened a group of critical access hospital staff, state Flex programs, hospital and healthcare association staff, and several quality consultants and quality program subcontractors for the express purpose of identifying what really attributes to a strong quality infrastructure in a and rural hospital. I was actually in my past role with Montana Hospital Association honored to be included in this group. And I want to give special credit and really put in the spotlight the Federal Office of Rural Health Policy, the Flex Monitoring Team, the National Rural Health Resource Center, and especially Stratus Health. These organizations have developed a really well-informed and valuable resource and data source for rural hospitals and the programs that support them. And especially having been able to be involved in this summit and involved in this project, I can say that these people truly understand and care about rural healthcare quality. So we will also provide links to the report for you to read in its entirety, as the report does deliver detailed information on quality infrastructure and the context to each element and the process of developing this as a whole. And while you'll see that the term critical access hospital is noted throughout the report and assessment, the content really can apply to all rural hospital quality programs. So if you aren't a critical access hospital, but you're still a small rural hospital, don't feel like you're left out. This is the place to be. So the assessment was released to state flex programs and data was collected from CAUSE from October to December 2023. So of the 1,370 critical access hospitals across the country, 1,221 completed the assessment. Now that's an 89% response rate, which is incredible. And so we have a really incredible bunch of data to look at here. So the intention is that this data from the inventory and the assessment will be used to inform state and national flex initiatives. But I also encourage, if anyone from state flex programs are on the call, to use their state specific data to maximize peer connections between hospitals in your state. For instance, electronic medical record peer groups or service line peer groups can be really valuable resources for CAW and rural hospital networking. I will have also linked a state flex program fact sheet for you to review that gives other ways and ideas that state flex programs can use the data. And this wasn't developed without what's in it for me for critical access hospitals. So hospitals can use this data to compare themselves to others in their state and nationally. They can use it to evaluate their own quality infrastructure and identify areas for interventions for improvement or strengthening. Please refer to the fact sheet that I've also linked for other ways the hospitals can use this information. So in the assessment, the data was collected in two parts. There's the inventory part and there's the infrastructure self-assessment. The inventory includes hospital service lines, quality measures, system measurement and management, electronic health record vendor and usage, and participation in payment models. So this gives us a really good picture of where critical access hospitals are and the landscape for rural healthcare. The infrastructure piece was developed to support rural hospitals to create sustainable quality infrastructure, looking at moving beyond measurement into performance excellence. The assessment evaluates 9 core elements of a COG quality infrastructure, and I want to recognize that these elements and criteria will naturally be nuanced in your state or your hospital. And the intention of our series here is not to say like this is what you have to do, but give you a broad overview of the elements and different ways to meet the criteria, so you can see how that works out in your facility. The 9 elements that the group came up with are aspects of the quality infrastructure that are necessary to have a robust quality program and a successful and resilient quality program. For each element, there are 2 to 4 criteria that list the ways that the element can be met or demonstrated. And to meet the element, a hospital must meet each criteria. Within this presentation, we'll go over the variety of ways then that each criteria can be met. So through this series, we're going to break apart the 9 core elements and kind of go over each one over the next few weeks. But to kind of get started, the elements are leadership, responsibility, and accountability. This is the hospital's ability to actively demonstrate that governance and administrative leadership support quality improvement. Element 2, quality embedded within the organization's strategic plan. We want to ensure that quality is an intentional component of the strategic plan and a process and part of the strategic plan process. Are we using quality methodology and ensuring that it's part of the process for each component or pillar of a strategic plan? Workforce engagement and ownership. This is really important we want to develop and support a workforce that understands that quality is a part of their job, just like washing their hands, and that we want to embed quality in everyday work. Having a culture of continuous improvement through systems. We want hospitals to design and manage systems and processes that support continuous quality improvement. And then also that culture of continuous improvement through behavior. Does the hospital support quality improvement behaviors that embrace innovation, motivation, and accountability? Integrating equity into quality practices. Are we being intentional about our quality improvement activities to ensure that they're equitable and ensure that they're not building a greater inequity somewhere else that we're unaware of? We want to ensure that everyone has a fair and just opportunity to be as healthy as possible. So integrating these equity concepts into quality practices is really important for that bigger picture and that community health and really moving change. Engagement of patients, partners, and community. Is the hospital intentionally building external relationships with our patients, our partners in the community to enhance access and resources and collaboration and improve the overall care experience? A hospital doesn't work as a silo in the community, it's really a team effort. And then data. Are we collecting meaningful and accurate data? We don't want garbage in, garbage out data, and all the work we do with data, we want to make sure that it is meaningful and accurate. And so applying a multidisciplinary approach to identifying key quality metrics and being able to prioritize and have complete and accurate data collection. Then using that data to improve quality. So we spend all that work collecting data. How can we use it to improve quality? And so we're recognizing internal and external data resources, using them meaningfully and transparently to improve quality improvement. And we'll go into each of these deeper throughout this short series. So here are the overall national outcomes for the 2023 assessment. Um, Nationwide, hospitals have an incredibly strong foundation with over 90% demonstrating leadership responsibility and accountability and a culture of continuous improvement through systems. These are like the core pieces. We can't go anywhere without our leadership being on board, and we have to have that system to support everything else. We can also see that nationwide, there are some areas that hospitals really need coaching, leadership, and support. Only 23% of hospitals can demonstrate integrating equity into quality practices. And this makes sense. It's not a negative, it makes sense with where we're at. As evaluating this equity and social drivers of health at the hospital level is still relatively new, but the data validates the need for stronger support, coaching, and guidance for rural hospitals in this area. So, why is quality infrastructure so important? It is important because it provides a framework for healthcare providers and staff to work in a system that's safe for continuous quality improvement and puts the patient first. And by safe, I mean more of our psychologically safe, where quality improvement is not punitive and the goal isn't to shame and blame. It's simply about solving a problem for the benefit of our patients and colleagues. Quality leaders in the hospital serve a really vital role as coach, facilitator, and collaborator. But I want to stress that quality improvement is no longer one person's job. It's a part of everyone's job. And a strong quality infrastructure ensures that there's resilience in the quality culture no matter what life throws at you. There could be staff changes or, like a global pandemic. So having that strong infrastructure will help a hospital and keep with the quality practices and keep patient care at the forefront. So, this session, we are going to talk about the first element: leadership, responsibility, and accountability. So, this means to actively demonstrate governance and administrative leadership support for improving quality. 95% of the hospitals completing the assessment can demonstrate meeting this element, which is incredible news because, like I said, we have the first step nearly done, and that's getting leadership on board. So there are three criteria to this element. Criteria one, the hospital board engages in and supports quality improvement. Criteria two, our executive leadership oversees design and functionality of the QI program. And criteria three, organizational resources are adequately allotted to support QI. So we can see that each score incredibly high. So it seems to me today I might be telling you something that you already know. So if that's the case, just bear with us. But we'll still talk about each criteria and the ways to meet. Feel free to stop me for questions. For me or for your peers on this call, we have over 50 people on the call today from hospitals and state flex programs and state hospital associations. So it's not just me that can answer questions, it's others as well. So you can stop and unmute or put something in the chat. So just kind of an orientation on the following slides. Our dark blue here is the criteria and the lighter blues or grays are ways to meet the criteria. So remember that a hospital doesn't need to do all of these ways to meet the criteria. They only need to do at least one to meet the criteria. So criteria number one, the organization's board engages in and supports quality improvement. How can we demonstrate that this is happening? The first is quality, performance, and strategies are a standing agenda item and are discussed at every board meeting. Quality directors, leaders, managers, and staff participate in the board meetings. The board has a quality subcommittee, or the board or a board member serves on the hospital's quality committee. So let's dive into the first part of criteria number one, and that is quality, performance, and strategies are a standing agenda item and discussed at every board meeting. Before we get going, I want to point out QAPI. So QAPI, you'll see through these presentations that a lot of this aligns with that. And it's an acronym for quality assurance and performance improvement. and references the methodology required by CMS and regulations. And I put the CMS standard, the general standard here. There's more details in the conditions of participation, but so the general standard for QAPI is that the cause governing body or responsible individual is ultimately responsible for the cause QAPI program and is responsible and accountable for ensuring that the QAPI program meets the requirements of the QAPI program design and scope. So that's meaning that your board is essentially responsible, and they need to ensure that it meets the scope and complexity of the organization. So how are some ways we can see this as a standing agenda item and some involvement from the board? So at minimum, the board actually must address the QAPI plan, um, and which is our QAPI performance and strategies annually based on those QAPI regulations. So the two things they must do annually is review and approve the QAPI plan and review and approve the organizational improvement priorities. Other performance and strategy items that the board can participate in is reviewing regular reports on quality outcomes, um, having conversations and reviewing and improving prioritization criteria for selecting QAPI projects. There's a lot to go in with. We can't do everything at once, so we need to have some sort of way to prioritize and plan. Um, and then ensuring that the organizational improvement priorities and projects are appropriate for the scope and complexity of the hospital. The second piece of criteria one, quality directors, leaders, managers, staff participate in board meetings. If quality isn't a standing agenda item, are our quality leaders and staff still being asked to participate in some way? And what does this participation look like? So it can look like coming and talking about a dashboard of quality metrics, sharing successes and opportunities seen within the hospital. Um, Big emphasis on successes because we want to celebrate the work being done, even if it's having a successful small test of change, we want to celebrate that. Our quality staff and leaders can provide continuous quality education for board members. Often board members don't have that institutional knowledge already of what quality improvement is, and our staff can help educate so they better understand the information being presented to them. And then have opportunities for board members to ask questions and discuss quality metrics or methodology or processes. The third piece of criteria one, the board has a quality subcommittee. So the role of a board level quality subcommittee would be to really support the organization's quality priority, keep bringing quality to the forefront, and keep ensuring that that's part of our priorities, our strategic planning, and our conversations. A board level quality subcommittee will also provide oversight to quality initiatives across the facility and help recommend appropriate resource allocation. I feel like that's a really important one. We want to have someone in our corner that's saying, this is important. We need to, as an organization, allocate resources to support it. I have a link on the slide. The American Hospital Association Trustee Services has a great system or a great outline of board quality committee guidelines. So if you're looking at building that or looking at your board quality committee, you can access that resource. Or instead of a board level quality committee, a board member might serve on the hospital's quality committee. This is an incredible opportunity to build a quality champion and someone on the board that has taken the time and effort and interest to understand QI methodology and processes. They will really be your cheerleader. It can help bridge that gap in understanding between hospital functions and operations and quality and to the board level. Criteria two is organizational resources are adequately allocated to support quality improvement. And there are a variety of ways to meet this criteria. There's actually 7 different ways to meet this criteria, kind of think of them as a checkbox. But first, I want to talk about pathways for education and training. Does your facility support training, certification, or organization memberships? Um, In the chat, I'd love for you to share different ways. I mean, this is a high scoring criteria, but I'd love for you to share different ways that your hospital provides education and training on quality improvement for your quality leaders or for all staff. Um, some ways that we can meet this is the hospital ensuring that funding is available on a yearly basis for at least one staff member to attend a quality related training or conference. Um, or for a staff member to pursue a quality relevant certification. I know that the CPHQ, Certified Professional Healthcare Quality, is a really valuable certification for quality staff. And then also, is there funding available for a staff member to have a membership in quality focused professional organizations like like NAHQ, the National Association for Healthcare Quality? And is there quality relevant on-site training for staff at least once a year? Other ways to meet this criteria are time and resource investments. I know rural hospital staff wear so many hats that it probably feels like they are going to topple over any day. But quality is really such a foundational piece of the work in the hospital and is more than just data reporting. So investing in staff education, staff time, tools, and training really helps build a strong facility-wide quality program. Criteria 3 is a QWOPI regulation, actually. So having executive leadership oversee design and functionality of the quality program. So our executive leadership can review and give feedback of the QWOPI plan. Even though they might not be involved in quality, like a quality leader or anything, they have that overall hospital view of what's going on and can help connect those dots. Um, Executive leaders are a great resource to share your quality improvement successes and measurement priorities to internal and external partners. Executive leadership can sit on the hospital quality committee and participate in performance improvement teams. So there are a variety of ways that we can also have our executive leadership involved in the process that are incredibly valuable. Okay, do we have any questions for me, for your peers, about the leadership responsibility and accountability, or about how the infrastructure assessment was developed? I'm happy to answer any or facilitate any conversations between peers. Okay, well, I really didn't expect any questions or concerns because this is such a high performing area of the assessment. And I think everyone should be really proud of that and celebrate that achievement. So up next week, we will be talking about quality being embedded within the organization's strategic plan and workforce engagement and ownership. So we're excited to share some thoughts and ideas about the infrastructure in these categories. So as we wrap up, we would love for your input here at Convergence. So you can either scan the QR code, you can click on this link, or when you close out of the webinar, there will be an evaluation that pops up, a short evaluation. We'll provide resources that I mentioned during the presentation through the follow-up email and linked in the slides as well. And please reach out at any time. My contact information is here, and I've also provided a link to the Rural Center website that has the report of the quality infrastructure assessment. It has all the details, it has fact sheets, it has resources, so that you can learn more if need be. But by all means, please reach out to me with any questions or thoughts, or even just kind of bouncing ideas off of. So with that, I want to thank you all for your 30 minutes this morning or 26 minutes this morning. Have a great day, and we hope to see you next week. So thank you all.